So, hello everyone. Welcome to our multi-head seminar. I've got only one case today, but it's quite interesting and rare. This is a PET CT of 44-year-old male, and he was diagnosed with this big tumor in the neck area. The tumor destroyed some vertebra, and it's probably not best seen on these scans, but tumor involved the upper thoracic aperture and also involved the thoracic cavity. But the radiologist described that the lungs were free of any tumors. I'm not sure about that, but they said it. So this quite huge malignant tumor mass in a young male. Môžeme prepnúť teraz do mikroskopu. So this is the histology of the tumor, and I've got already this high magnification, and you can see this highly malignant looking epithelioid and in some parts almost rhabdoid cells with vesicular nuclei and prominent nucleoli, some necrosis. Okay, the clinicians were, the clinical diagnosis was probably sarcoma. Okay, so this is the highly malignant histology, and by immunohistochemistry the tumor was at least focally positive for cytokeratins. This is cytokeratin cocktail. Not all tumor cells are positive, but there is some patchy positivity for cytokeratins. And surprisingly, the tumor cells were also positive for TTF1, thyroid transcription factor 1, but the positivity is this mild to moderate only, not very strong. But I believe that at least some tumor cells are TTF1 positive. And all other stains used were negative. There was a broad panel of markers, and we have included one antibody, which is SMARTSA4 or BRG1 protein. And you can see positive staining in stromal cells, in endothelial and inflammatory cells, and loss of BRG or SMARTSA4 staining in tumor cells. So when combined with the clinical findings, we've got thoracic tumors, tumor probably with involvement of upper mediastinum and this huge soft tissue mass destroying soft tissue and bony structures. The diagnosis is undifferentiated SMARTSA4 thoracic tumor. The name for the tumor was chosen tumor because it's quite controversial entity still, and we still don't know whether it's a sarcoma or the differentiated carcinoma. Môžeme switchnúť na ten PowerPoint, prosím. Druhý. So this is the name, official name, according to WHO classification is thoracic SMARTSA4 deficient undifferentiated tumor. And there are some works, probably Michael will show us some papers, at least in a proportion of cases, well-differentiated epithelial component may be found in these tumors with morphology of adenocarcinoma or squamous cell carcinoma, and these patients are smokers or former smokers, and the genetic signature of the tumor is associated with smoking, so probably at least proportion of these tumors are the differentiated carcinomas. And the mutation spectrum is very similar to pulmonary cancer, but when RNA sequencing was performed, and this is the clustering analysis after RNA sequencing, these SMARTSA4 deficient thoracic tumors are clustered together with malignant rhabdoid tumors and small cell carcinoma of ovary of hypercalcemic type. In contrast to the other cluster, which is epithelial sarcoma or poorly differentiated SNF complex deficient pulmonary cancer. So there's overlap, morphological and clinical, but based on RNA sequencing, this is a separate group of lesions. Okay, clinically it's very, very aggressive, and most patients will die in 6 to 7 months. Okay, but SNF deficient tumors, there are some ongoing studies with immune checkpoint inhibition. Okay, so this patient, our patient, is probably candidate for this targeted immune checkpoint inhibition. I went to the clinical history of the patient. He is ex-smoker, but he was smoking. So combined with this focal positivity of cytokeratins and TTF1 positivity, I believe that it may be the differentiated pulmonary carcinoma, but radiologists could not see any connection to the parenchyma, so I don't know really. So that's it from my side.
Hello everyone, it's Michael here. I have another case. This is a consult from last week. This was, I think, a young male in his 30s, like 32 years old. Tumor which mainly affected his mediastinum, but also there was some involvement of the pulmonary hilum, and there were these small damaged tissue samples where you, without much hesitation, can definitely see something very aggressive, something very infiltrative, something very dark blue. Unfortunately, due to the damage, it's quite hard to see the cytological details in most of the cells, but there are areas where it is possible. So invasively growing, partially necrotic, very dark, very aggressive looking neoplasm. Okay, I'll show another block where the cytomorphology was more easy to appreciate. And here in some parts you can see this kind of epithelioid, again rhabdoid morphology, quite similar to the previous case. And now I will go with some immunomarkers. These are broad spectrum cytokeratins. So there is some expression, not diffuse strong, but definitely at least patchy positivity is there. There is no doubt. And there was a very diffuse expression of EMA. So 2 epithelial markers are positive. There was some CD34 positivity, P63, P40 positivity, but we stained a few other markers, and the submitting institution stained a lot of other markers which were negative, including NUT immunostain. Eventually we did sequencing, and the molecular analysis detected multiple mutations, including TP53 and some others, as well as SMARCA4 mutation. And indeed, by immunohistochemistry, this is SMARCA4. You again see very clear lack of expression in the tumor cells, while the stromal cells, vessels, and inflammatory cells are nicely positive. So this is another case of SMARCA4 deficient thoracic undifferentiated malignant tumor. Then in a 32-year-old patient, it's really a tragical diagnosis in this age. I'll just show one. Okay, I'll show one paper. This is probably the best paper on the topic, from the New York group, who for the first time showed these tumors are most likely, in most cases at least, related and derived from carcinomas of the lungs. So if we go down right in the abstract, they nicely summarize their findings, that the relationship of SMARCA4 deficient thoracic sarcomatoid tumors with SMARCA4 deficient non-small cell lung carcinomas, because it's important to note that there are well differentiated squamous cell carcinomas and adenocarcinomas of the lung, which can show SMARCA4 deficiency. By the way, it's quite clinically useful to know that these well differentiated non-small cell lung cancers, which are SMARCA4 deficient, often don't express TTF1. So whenever you expect, you are looking at a pulmonary adenocarcinoma or squamous cell carcinoma, and the adenocarcinoma is TTF1 negative, maybe it's a good idea to add SMARCA4, which might indirectly point to the possibility that it is indeed pulmonary tumor, despite the TTF1 negativity. Anyway, they compared, in this study I'm showing here, they compared the thoracic so-called, previously called sarcomas with SMARCA4 deficiency to non-small cell lung carcinomas with well-differentiated histology and SMARCA4 deficiency. So they confirmed the relationship of these two groups together because of the presence of non-small cell lung carcinoma component often juxtaposed with the sarcomatoid or sarcoma-like areas in a subset of cases, in 5 cases out of 45, I think. There was focal expression, as we saw in Marianne's case, focal expression of TTF1 or P40 in some, again, in a subset of cases. In our case, I've just shown there was P40 and P63 expression indeed. They also showed, similar to other papers before, that most cases of these tumors, which were thought to be sarcomas, most patients have smoking history. They also have genomic smoking related signature, which is basically unheard of in true sarcomas. And also there's high tumor mutation burden similar to smoking related well-differentiated carcinomas of the lungs. So all these characteristics together suggest that these tumors previously thought to be sarcomas are in at least most cases originally carcinomas, which kind of like de-differentiated. The similar concept is now accepted in gynecopathology, gastrointestinal pathology, pancreatic pathology, and other sites. So it kind of makes sense as well. Very perhaps useful finding is that many patients had emphysema, which is also, of course, related to the smoking history, but there were few patients in this study who didn't smoke, they were never smokers, but they still had emphysema for some other reasons. So probably these patients without history of smoking who develop these tumors might have this might have association to their underlying lung pathology, the emphysematous changes. So here we see the typical morphology. There is SMARCA4 deficiency, also SMARCA2 deficiency. There is typically Claudin-4 loss. Claudin-4 is like an epithelial marker, present in most carcinomas. The epithelial markers, cytokeratins and EMA, can be focal. Rarely they can be completely negative as well. And here are some of the well-differentiated lung carcinomas on the right and undifferentiated component on the left. You can see the difference in cytokeratin and Claudin-4 expression, and SMARCA4 is lost in both components. SMARCA2 is lost in the sarcomatoid part and is present in the better differentiated part. Here, sorry, I skipped the H&E at the beginning. Okay, here are some scattered, better differentiated areas of lung cancer in a few cases, again confirming the relationship between these tumors and non-small cell lung cancer. Comparing the clinical pathological features, including survival, you can see the sarcomatoid tumors, the completely undifferentiated rhabdoid tumors we've just seen. They have much even worse prognosis than SMARCA4 deficient non-small cell lung carcinomas. They also are typically much larger, and there is a very strong male predilection. Three quarters were males. So this is generally very useful paper, which you will be able to find this on our website after this session. So next case is this. This is a 40-year-old male, tumor of the chest wall, measuring 14 centimeters in the largest dimension. And this is just another case of the same tumor, this time just with much nicer morphology than in the previous case. This beautiful rhabdoid, quite distinct rhabdoid features. This was diagnosable from, we thought about SMARCA4 deficiency from the H&E. In the previous case, I must say I thought of it first after the molecular testing. So SMARCA4 lost. And these undifferentiated rhabdoid tumors also show SMARCA2 loss, which is in contrast to most of the well-differentiated or better differentiated squamous cell carcinomas with SMARCA4 loss. They are usually SMARCA2 retained. Actually, these tumors, I always thought they are super rare, but this was the third case this year for me, and Marianne's case is actually the fourth I've seen this year. So I think that they are not so rare, not super rare. Okay, now a different topic. This is a cutaneous tumor from a sun-exposed skin somewhere on the head and neck. Skin excision, and you can see this ovoid small tumor. You can look at the epidermis. Here there's some atypia. It's always hard to say whether it's reactive due to the tumor right underneath or whether this is true dysplasia. But in any case, we see this nice tumor composed of quite voluminous clear cells which have quite atypical nuclei. There was also some mitotic activity. It wasn't super brisk, but there was some. So in this case, you can of course include a broad differential diagnosis. Definitely melanocytic lesions, some balloon cell nevus should be excluded. You should think of some renal cell carcinoma metastasis, some pecoma, and tumors like this. But essentially every immunohistochemical staining here done was completely negative, besides CD10, which is generally completely useless marker because it's positive in many tumors. You can see the actinic damage here. And I think once you see this tumor, you will not forget what this is. This is actually a clear cell variant of atypical fibroxanthoma. Atypical fibroxanthoma is a relatively common tumor, which is considered generally benign or very low-grade malignant, basically if it's excised completely, and the diagnostic criteria are correctly used. It's mostly benign, but very rarely recurs. In general, atypical fibroxanthomas should be present on sun-exposed skin, sun-damaged skin. They should be limited to the dermis, and there should be no major invasion into subcutis, such as you can see here. There should be no vascular invasion or perineurial invasion. Most atypical fibroxanthomas, I think most people that are listening or watching have seen a case. Those are mainly kind of atypical spindled to pleomorphic dermal tumors, and most are actually very boring histologically, but this clear cell variant is quite beautiful, I would say. Quite interesting to see.
Eye-catching.
I have the case you had a few weeks ago. I have it here. I think this is maybe it. Just another case. Again, sun-exposed skin, sun damage here. And it looks like basically like another block from the same case. Beautiful.
I think these are usually sarcomatoid carcinomas.
Yes, I'll get to this. There is a very valid theory that these tumors are closely related, or perhaps are in fact sarcomatoid squamous cell carcinomas lacking cytokeratin expression. I'll get back to it later. Again, in the second case, there was everything negative. I'll show it later. Another case. This is a third patient. Again, you can see the morphology is identical, clear cell variant. In each of the cases I've shown, there is some atypia in the epidermis, so you can think about potentially this being really sarcomatoid carcinoma. Another case here, still the same topic, although this looks different. I just thought I'll show some weird atypical fibroxanthomas I've had recently. Again, sun-exposed skin, and then in the dermis, you have this quite well circumscribed nodular tumor, same silhouette as the cases before. But in this case, you can see a lot of giant cells, in between quite many atypical cells with very brisk mitotic activity. So again, this case needs a lot of immunohistochemistry, definitely exclude melanoma, some carcinomas, and perhaps also other tumors, but essentially every IHC was negative. So this was giant cell variant of atypical fibroxanthoma. One more case of the same. Again, I'll go on low power. This nodular, well-circumscribed tumor limited to the dermis, where you have a lot of giant cells, a lot of atypical cells with a lot of mitotic activity, every IHC negative. So this is a giant cell variant of atypical fibroxanthoma. And now to the relationship of these tumors of atypical fibroxanthomas to squamous cell carcinomas or sarcomatoid squamous cell carcinomas. Whenever you are trying to study the relationship of various tumors, either transcriptomic analysis or methylation analysis can be useful to kind of like visualize the relationship. And here you can see the plot here. The orange is atypical fibroxanthoma, AFX, / PDS. PDS means pleomorphic dermal sarcoma. Those are basically the same tumors, but with invasion into the subcutis, which completely or little bit changes their outcome. Whenever there is an invasion into subcutis, there is a possibility for metastasis and more aggressive behavior. So that's why you should stick to the criteria very strictly to call something AFX. There must be no invasion in subcutis. Whenever there is, it's pleomorphic dermal sarcoma. In any case, these tumors are the same. It's just a continuum. It's just a different stage of the same tumor. This gray bluish color, that's a sarcomatoid squamous cell carcinoma. You can see the overlap with AFX, which I think for me this supports the notion that at least a large part of AFX is basically completely undifferentiated sarcomatoid squamous cell carcinoma. And there is a strong relationship to those. The same on this heat map. The orange and black are AFX and pleomorphic dermal sarcoma, and this light blue is squamous cell carcinoma. You can see that it is intermixed. The clustering again shows the nice overlap. Okay, that's another topic. Another case. This is a consult case from Pakistan. It's from the peritoneum in the liver, in the kidney capsule. Here is the underlying peritoneal tissue, and in this part you have this weird tumor with, I think anybody who sees this might start thinking about adenomatoid tumor, especially on the peritoneum, or especially on serosal surfaces, but it can be also like intrauterine, for example. But this is not adenomatoid tumor. It might be something closely related. So when you see this, you can start doing some immunohistochemistry. There was a diffuse cytokeratin expression. I don't have the slide here, but there was. There was a quite diffuse WT1 expression. So I'm showing mesothelial markers now. WT1 is a nuclear marker, so let's look at the nuclei, and indeed they are quite strongly diffuse deposited for WT1. There was a limited expression of calretinin, which is another another mesothelial marker. This is more of a cytoplasmic marker. It's not a beautiful expression, but I think there's a bit of it. D240 was completely negative. Now you can either call it adenomatoid tumor, or if you follow the literature, you might have seen this paper by nobody else than Abbas Agaime, who found NR4A3 fusions in tumors with identical morphology. There was limited follow-up, but basically all 6 or 7 cases, all 5 cases were without evidence of disease. The case 6 and 7 were possibly something else because they didn't have the fusion. You can see the fusion spectrum here. It's both EWSR1 and NR4A3 fusion, as we know from extraskeletal myxoid chondrosarcomas, or there are some other NR4A3 fusions involved. All the cases occurred in the peritoneal cavity. They were either localized or diffusely involving the peritoneal cavity. Either this small lesion here or more widespread disease, and the morphology is essentially the same. So very similar to adenomatoid tumor, which we have limited information, but these tumors look, the NR4A3 look benign, but we need more clinical information and longer follow-up. But if you mistaken it for adenomatoid tumor, it's probably not the biggest mistake. The biggest mistake would be to mistake this for mesothelioma, malignant mesothelioma with adenomatoid features, because these areas can occur in conventional epithelioid mesothelioma, but you should also see the conventional high-grade part. So these are more unusual-looking areas in these tumors. Generally, I think more difficult would be to distinguish this from adenomatoid tumor than from adenomatoid mesothelioma. with regard to the differential with adenomatoid tumor, the adenomatoid tumors generally have more solid growth, more kind of like epithelioid cells. This tumor I'm showing here is usually composed of these cystic spaces lined by very flat cells. If you can, I'll show it again. We go on high power. Most of the cells here are really very flattened. Very few have some cuboidal shape, and basically none have this plump epithelioid morphology such as you often see in adenomatoid tumors. So this is, I think, a new entity in peritoneal pathology. Good one to remember later. Okay, another case. This is more mundane pathology. This is a consult case from last week. Adult person, doesn't matter whether female or male. It's a soft tissue near the knee, and all you see here is a fibrous and myxoid tissue with fat tissue, and this small myxoid tumor with this prominent curvilinear vessels, few interspersed bland spindle cells without atypia. So this is some myxoid lesion. When you have bland cells, this vasculature, you can think of myxoma. And whenever you are close to a joint, you call it juxta-articular myxoma. So completely benign lesion. Okay, this is a quite challenging case from retroperitoneum, adult person. There were 4 small core biopsies, which mostly consisted of this necrotic tissue. Some spindle cells here, but I'll show the one block, the only sample where there was something to look at, which was this one. So besides the necrosis, you have this area with quite atypical but relatively monomorphic spindle cells, which are very cellular. There is some mitotic activity. And because you are in the retroperitoneum, definitely you should start with MDM2, because the dedifferentiated liposarcoma can definitely look like this. MDM2 was negative, completely negative though. Second option for me with this morphology would be a malignant peripheral nerve sheath tumor. So you can try S100 protein, which is here. And this tumor is either negative with S100 or very focally positive. So should that discourage you from pursuing malignant peripheral nerve sheath tumor or MPNST? Definitely not, because a large proportion of MPNSTs is completely negative for S100, despite the fact that these tumors are neurogenic. So you just have to stick with clinical features and morphology, and you can, by immunohistochemistry, you can use basically only one more help, which is this still relatively novel marker, H3K27 trimethylated form. It's some histone marker, which is lost in a large proportion of MPNSTs, not all of them, but some 70–80% of cases have complete loss of this marker. So you can see nice loss with, again, positive endothelial cells. So for me, due to this very small size of the lesion, it's not a definitive MPNST, but I sign it out as a spindle cell sarcomatoid tumor, most likely a sarcoma. Differential diagnosis on the first place includes malignant peripheral nerve sheath tumor. Just to compare, this is another case. It was a 44-year-old male with a tumor on the thigh. It was quite superficially located tumor, and this is a very illustrative case of MPNST, of malignant peripheral nerve sheath tumor. So just to show you what I was talking about, this is a textbook example where on low power you see this variable light and dark areas, this kind of like mosaic or marble-like pattern. The dark areas represent the hypercellular areas, whereas the lighter are less cellular. Cytologically, these are mostly spindle cell tumors, which are relatively monomorphic with occasional interspersed pleomorphic cells. They can be present. They are not really present in this case that much, but they can be there. But whenever you see something highly pleomorphic, highly undifferentiated, it's unlikely to be malignant pleomorphic, malignant peripheral nerve sheath tumor. So a lot of necrosis is typically present. So now, what are other diagnostic criteria? You can call it MPNST either when the patient has a confirmed neurofibromatosis type 1. In such patients, whenever you see a spindle cell sarcoma, it's MPNST unless proven otherwise, basically. Then if you have S100 protein expression and the right morphology, it's also another criterion to call it MPNST. And now, again, with this histone marker, H3K27, in this case, again, complete loss, this, again, strongly supports the diagnosis of malignant peripheral nerve sheath tumor, which are generally high-grade sarcomas, of course. Often you can have some heterologous differentiations, rhabdoid differentiation, or chondroid or osteosarcomatous differentiation. Those are both pretty common, and in the right morphological context, I would say rather support the diagnosis than, so it shouldn't discourage you from the diagnosis. So another case, this is from our faculty hospital from last week. There was an old 80-year-old male with a tumor on his forearm, which was thought to be some calcified hematoma clinically. Well, it isn't, unfortunately. It's this multinodular tumor, which is, again, quite cellular. In many areas, it produces osteoid. Again, you see cellular spindle cell proliferation. So you can, this is definitely a differential diagnosis for malignant peripheral nerve sheath tumor. But the cytology is somewhat different. There's also quite a lot of these myxoid lakes. There are some areas often resemble sclerosing epithelioid fibrosarcoma, such as here. Again, here, sclerosing epithelioid fibrosarcoma-like areas. And because we are preparing a large study on these tumors, where we have almost 70 or 80 cases now, this was, I had a high suspicion for malignant ossifying fibromyxoid tumor, which, when you see this morphology, it typically has either B-core or TFE3 fusions. So I went to sequencing after doing very limited IHC panel, which was essentially negative for every major marker, including S100 and desmin, which are often positive in ossifying fibromyxoid tumors, but in the malignant subtype or subgroup are usually negative. So it didn't discourage me at all from the diagnosis. And when I got the results yesterday, there was no B-core fusion or TFE3 fusion, but there was actually B-core L1 fusion, which is a gene highly or closely related to B-core, and has been rarely described in OFMT as well. We have 1 or 2 such cases in our series as well. So this is a malignant variant of ossifying fibromyxoid tumor. With the conventional ossifying fibromyxoid tumors, you have still here the multinodular architecture, the fibromyxoid stroma, and of course the ossified or osteogenic differentiation, although it's often missing in the malignant subtype. So not a calcified hematoma. Okay, how much time do we have? Okay, so another topic. This is a retroperitoneal tumor, I think. If I have the right information, it's an old case. So retroperitoneal tumor, and this is one of those completely undifferentiated high-grade tumors, like the worst histology you can probably imagine. But we are in the retroperitoneum. It's an elderly patient, so we should think always about dedifferentiated liposarcoma. In this case, it wasn't that tough, if I remember correctly, because there were some areas, or maybe there was the other case I have prepared for you with, okay, there was another case. Sometimes you can see like a high-grade lipogenic region, but in this case we had MDM2 immunostain, which is here. You can see strong nuclear expression of MDM2. There was high level amplification by FISH. So this is epithelioid or rhabdoid dedifferentiated liposarcoma, which is a subtype described simultaneously a couple of years ago by Abbas with our support, and by one Asian group. I unfortunately forgot which one was that. You can see it's somewhat similar to the SMARCA4 deficient subgroup, but this is just more pleomorphic. The cells are even larger than those. There's obviously no SMARCA4 loss. Otherwise, you can have cytokeratin expression in these tumors, desmin, myogenin expression. So don't mistake this for rhabdomyosarcoma, pleomorphic rhabdomyosarcoma. Always go for dedifferentiated liposarcoma in retroperitoneum with this morphology, or second consideration should be dedifferentiated melanoma. So this is the paper by Abbas. These are highly aggressive tumors. Obviously, they look like it. And typically occur either in the retroperitoneum, or they may also involve like the inguinal canal and thigh. And again, some of these stains. This is myogenin here. This is desmin. So don't get discouraged. Always do MDM2 when you are in the retroperitoneum. Some cases may have these lipogenic areas, which is a great help, of course. And here the table shows MDM2 IHC uniformly positive, as is MDM2 FISH. Okay, this is another case. This is less bizarre. It's more the cells are somewhat smaller, but still epithelioid to rhabdoid. And it's probably this case which had the lipogenic differentiation somewhere in the corner. So in this case, you don't necessarily need MDM2, although you could think about some pleomorphic liposarcoma perhaps. So it's good to do at least MDM2 IHC here. So that's one bizarre variant of dedifferentiated liposarcoma. These tumors are another great mimicker of anything similar to melanoma. I always thought that the only morphology they cannot have is a small round cell morphology, but I was shown wrong relatively recently. So basically any morphology can, the differential liposarcomas can have almost any morphology basically. So think of them especially in the retroperitoneum. This is another case in the retroperitoneum. This is relatively bland spindle cell proliferation with a lot of inflammation, So you could think of some inflammatory myofibroblastic tumor, but notice these hyperchromatic large cells scattered throughout the lesion. And again, this was MDM2 positive. These bizarre cells were MDM2 positive at this IMT-like dedifferentiated liposarcoma of the retroperitoneum. Here is the IHC. You can see most cells are negative, but the biggest ones, which were hyperchromatic, are nicely positive. Okay, now we have another retroperitoneal lesion. This is an adult patient with a perinephric tumor. You can see the kidney, and here somewhere in the kidney capsule, you have this myxoid tumor with some weird cells, which are a little bit hyperchromatic as well, as you can see here. So this is definitely, again, MDM2 without you think about anything else, just order the IHC stain. But in this case, it was negative. MDM2 amplification was also negative, but don't think that dedifferentiated liposarcoma cannot look like this. I've had a case which looked basically identical, but just had the IHC positivity and MDM2 amplification. But this case I'm showing here was negative for these markers. In such situations, it's good to consider this relatively rare entity, which it's unknown whether it's a neoplasm or some pseudo neoplasm, but most likely it's non-neoplastic perinephric myxoid pseudotumor of fat, described by I think Brian Rubin for the first time. As the name implies, it's always around the kidneys somewhere. Very often it's associated with some other kidney pathologies such as diabetes or pyelonephritis. And essentially the morphology is always the same as we saw in our case. This myxoid hypocellular proliferation with scattered weird cells, which are, however, MDM2 negative. There is no other way how to distinguish this from dedifferentiated liposarcoma than by FISH or generally molecular studies and by IHC. So perinephric myxoid pseudotumor fat. Again, the PDF will be online after this session. Do we have time? Okay. So I'll probably have time to show all my cases. This is an older case, a 65-year-old male, tumor of the thigh. That's a case from my colleague Zdeněk Kinkor, which was this case was amazing, and I must say I was amazed how Zdeněk diagnosed it. Very necrotic, very aggressive looking tumor. Mostly spindle cell in these areas, but if you move somewhere else, you can see a big proportion of epithelioid or more epithelioid cells as well. You can see that there is, it's necrotic, it's very ugly, but there is no major pleomorphism here. So you can always, whenever you see relatively monomorphic tumor, you can always think that there might be some fusion or mutation. So in such cases, I would always suggest do some basic immunohistochemical panel, some cytokeratins, desmin, S100, vascular markers perhaps. CD34 is very useful. So in this case, we had cytokeratins when I find them. This is Oscar antibody, which was quite positive in many areas. Then there is desmin, which was essentially negative. Maybe a few cells here. So I think most people at this point would give up thinking about rhabdomyosarcoma and would move away from the diagnosis, but not Zdeněk. And I adopted this approach whenever I see high-grade spindle cell or high-grade lesion which is composed of large proportion of spindle cells. Besides desmin, I will do other skeletal muscle marker, especially MyoD1. MyoD1 is for me the best. And this is MyoD1. This is completely positive for MyoD1. Cytokeratins were positive, and you can also stain it for ALK, diffuse positivity for ALK. And these tumors were have been have become quite well known, much better known than several years ago, because they are important. They are typically present in craniofacial bones of young adults, and this is basically a new subtype of rhabdomyosarcomas with TFCP2 fusion, highly aggressive malignant tumors, which, however, sometimes can be present in soft tissue as well. They don't always have to be intraosseal, and they don't always have to be in the head and neck area, but this case is again from the thigh. So you can see, occasionally you can encounter it in soft tissues proper. The ALK positivity is due to some ALK alterations, ALK mutations in other genetic changes, and there has been attempts for ALK inhibition by oncologists. Sometimes it helped a little bit, sometimes it didn't have much success, so it doesn't seem to be the new hope for these patients. And last case, this is more of quite regular pathology, some inguinal lymph node, axillary lymph node, 23-year-old female. So you can see a lymph node with a lot of vessels, some vascular proliferation. So you can start thinking about some hemangiomas, but this is a lesion known for many years. I think it was described by Juan Rosay, if I'm not wrong. It's called vascular transformation of lymph node sinuses, and typically occurs when there is some blockage of the efferent lymphatic vessels by whatever can cause the obstruction. So this is non-neoplastic lesion, vascular transformation of lymph node sinuses. Okay, that was my last case. Okay, and that's all from us today. So thank you for watching, and see you next week. Oh, sorry. So there are a few more cases. So that's all from me.
Okay, I would like to stress that you can download all reprints from our website, so that do it if you are interested. And I'm going to present here one result from Vancouver, from Canada, which was a tumor of thyroid. You see there is nodular hyperplasia around. And all of a sudden there was a small nodule that looked like that. Ale já mám to ostrý? Já to mám ostrý. Takže já k tomu snad musím relaxovat. Jo. I have here thyroglobulin staining. Where you can see that most of that nodule is thyroglobulin negative. And we did NGS sequencing, but NGS sequencing showed NRAS mutation, which doesn't say much because there is nodular transformation of thyroid, which can be NRAS mutated as well. Yeah, so that my interpretation of this interesting lesion is that it's probably a lesion arising from solid cell nests, maybe very incipient stadium of so-called mucoepidermoid carcinoma of thyroid, but still, I have it's just my impression. You can see the rest of thyroid follicles inside of the nodule, which still shows some thyroglobulin positivity. In the middle, you see some packs of the cells which are thyroglobulin negative. And I have this lesion taken from peritoneum. It's much more cytology than biopsy. We did because first our impression was that it might be a lymphoma. We did NGS sequencing for we did T cell rearrangement and clonality, which was negative. But still, when we try to do MIB1 positivity, you see that big part of the cells are MIB1 positive, so that it really is adept for malignant tumor. Yeah. Further, we did CD30. It shows that many cells are positive. So the differential diagnosis narrows it between Hodgkin disease and large anaplastic lymphoma. The tumor was ALK1 negative, and the final staining was PAX5, which showed these PAX5 positive cells. And even here, much better than in hepatoxylin, you see even double staining cells, so that our diagnosis was Hodgkin disease. I think it was, you can see it in the middle, yeah, the RSL, yeah. So it was then, I guess, confirmed by larger biopsies that Hodgkin disease. Okay, it's all, and it's 4:30. Thanks for attention. Next week we can see it again. And again, I invite you to download all reprints that will be on our webpage. Yeah, thanks.